Good afternoon, everybody. I'm Matt Salo, and I'm the Executive Director of the National Association of Medicaid Directors. And I'm pleased to be here this afternoon. I was invited by the good folks at Lilly to come take part in this eAdvocacy Summit to do the Medicaid workshop. And so we've got about an hour, and I know that Zach wants to take about the last 15 minutes or so to do some more intensive work on the social media aspect of this, but that gives us 45 minutes or so to talk about Medicaid and what's happening at the state level. And I want to talk a little bit about what's going on and also want to open it up to a little bit of a dialogue and discussion at the end. So please don't be shy with that, and hopefully we can find some time for all of that. So like I said, I'm with the National Association of Medicaid Directors, and we're the group that represents the 56 individuals in each of the states, the territories, and the District of Columbia responsible for administering the Medicaid program. And a lot of people don't really know what Medicaid is. Part of our challenge today is Medicaid is arguably the most important program in this country that nobody understands. And that's kind of true for a lot of reasons. And hopefully folks in the audience here have a pretty good sense of what it is, but I will do a little bit of background on it just so it helps everybody to put it in perspective. But Medicaid is, in essence, the largest health insurance program in the country. And talk a little bit about that. So Medicaid is commonly defined as the health insurance program for the poor, as opposed to Medicare, which is the health insurance program for seniors. Neither of those tags really does the respective program justice. And in fact, it's very hard to talk about Medicaid, and it's very hard to define it quickly and easily because what it does is so complex and, well, quite frankly, so confusing. It is, in fact, a program for some poor people, but the way that the program works is that if you actually look across the country, Medicaid only provides health insurance for roughly half of Americans who are below the poverty level. And that's due in part to the very confusing patchwork of eligibility for the program that exists. And in effect, what that means is that in any given state, Medicaid's role is a very heterogeneous one. I kind of describe it as a birth-to-earth program, because Medicaid pays for about 40% of all the births in this country. 40%. Now, in some states in the South and Southwest, you're up around 60 or 70%. Medicaid also pays for the majority of long-term care, whether that be in nursing homes or other non-institutional settings in this country. Birth to earth. It also does quite a lot in between. Medicaid is the largest payer for mental health services in this country. It's the largest payer of HIV/AIDS treatments in this country. It's the largest provider of disability services in this country, and on and on and on. But it's not necessarily the program for the poor, because the way Medicaid works is that in the current program, it's not enough just to be poor. Generally in Medicaid, you have to fit into a certain category. So if you're a pregnant woman or kids under 6, generally you're in luck. Medicaid's eligibility is fairly generous, hence why we have 40% of the nation's births covered by Medicaid. However, if you're a kid between the ages of 7 and 18, Medicaid's a little less generous. So you can have families where one kid's on Medicaid, the other kid is uninsured. The parents themselves, a different story. And again, this will vary significantly by state, but in the average state, parents of small children or of younger kids, if they make more than 60% of the federal poverty level, they make too much to qualify for Medicaid. And in some states, again, in the South, Southwest, you're looking at levels potentially around 20% of the poverty level. And then if you're a childless adult, whether you're single or married or what have you, generally it doesn't matter what your income is. Your income can be zero. You're generally not going to qualify for Medicaid. This confusing patchwork is why it's difficult to talk about it, why it's hard for policymakers to wrap their heads around it. And of course, that's compounded by the fact that because Medicaid is a program that is administered at the state level, many of the coverage decisions, the benefit decisions, and the structure decisions of the program vary by state. So it's a confusing program to begin with, but then when you find that, here in the district, the DC Medicaid program and the surrounding programs of Maryland and Virginia radically different from one another. Very confusing, very difficult to deal with. And it's a challenge we all have because, like I said, this is a very important program. Medicaid covered 62 million Americans last year. And we spent a combined state and federal $420 billion. And it's a program that continues to grow at rates that are beyond, I would argue, the comfort level or the capacity of either the states or the federal government to continue to sustain. So while I want to get into some of the major issues that are facing Medicaid today at the state level and at the federal level, because there's clearly a number of things going on with implementation of the Affordable Care Act and a number of things. But I want to put some of this into context and perspective because I think that's important as well. And I want to kind of give you a version of what I call the things that keep the Medicaid directors up at night. And there's a lot of them, unfortunately. So despite all this disparity, despite all these differences, despite all this heterogeneity, Medicaid directors are essentially uniform in their desire to try to provide the best quality care to the most number of people within very, very difficult budgetary constraints. And quite frankly, that is made all the harder when states are going through very difficult budgetary periods. And there is no question, certainly if you've paid attention to the national elections, there's no question that the topic of the federal budget, the federal economy, the federal recession, the federal drivers of recovery, that takes up a lot of attention. And lots of questions on both sides about who's got the best solution. But what's often left out of that discussion is the impact of the economic changes on the states. Because states have been hurting as well. And in fact, since the recession hit, state revenues and state economies hit essentially the worst period since the Great Depression. And while they have rebounded, state economies are getting better, jobs are coming back. State revenues have yet to return to the pre-recession levels. So we're closing in on 2013. We have yet to get back to where we were in 2008. And why is that important? That's important because, on one hand, Medicaid is an interesting program in that it is what we call counter-cyclical. And what that means is that at the time when states are least able to afford contributions to Medicaid during a recession, that's the exact time that the need for the program is the greatest. Recessions happen, people lose work, people become uninsured, people end up on Medicaid exactly at the time when states don't have the money to pay for it. And you could say, well, why don't you just do what the federal government does and pass the problem on to somebody else or somebody's grandkids? And the challenge is that at the state level, every state has a balanced budget requirement, which means that every year, or a biennium in some states, you got to reconcile revenues in and spending out. And when revenues go through the floor, that leaves states with very, very difficult decisions. Because at the end of the day, for a year or two, you can kind of move money around and you can rebalance things and draw on rainy day funds. But in an extended recession like the one we've had, it forces very difficult decisions. And at the end of the day, you're really left with two major options when you're talking about budget shortfalls of the nature we're talking about. Those two options are significantly raising taxes or significantly cutting spending. And again, if you live in a state, and I imagine most, if not all of you do, you know that the political appetite for raising taxes isn't there. So that's left states with cutting spending. And Medicaid is 20% or so of the average state budget. So it's a pretty appealing target. So states have been finding themselves in this very tough position of, at a time when the country needs Medicaid the most, when people are uninsured, when people need to rely on Medicaid, states have been struggling with how to keep the program afloat and with the desire and the sort of the struggle to try to reduce spending. Now, part of the challenge is that that's not going to work either. You can't, we've discovered that we really just can't cut our way out of this problem. Medicaid is, I'll oversimplify this, but Medicaid as a budgetary item, as a program, is a function of a simple math. We pay providers to deliver services to people. And that's essentially what we spend $420 billion a year on. And so the desire to reduce spending generally comes with, a need to hit somewhere along that equation. If you covered fewer people, you could spend less money and maybe balance your budget. If you covered fewer services, you could spend less money, balance your budget. Or if you paid providers less, spend less money, balance the budget. And that all works in theory. That no longer works in reality for a variety of reasons. Like I said, we cover 62 million people right now. Current federal law prohibits states from reducing eligibility. You can argue that's a good thing. Don't want to increase the number of uninsured in a recession. I get that. But one option that's off the table. Paying providers. Medicaid doesn't pay providers well to begin with. And if you're a provider group or you know this, look at primary care. For primary care physicians, Medicaid on average pays about 70% of what Medicare pays. Medicare only pays about 70% of what the private market pays. It's a pretty low threshold upon which to get a whole lot of savings. And then services. What does Medicaid provide that it doesn't need to, or that people could live without? Prescription drugs? Technically optional. Could get rid of it. Not going to happen. Not a good idea. Long-term care? Nursing home coverage? A lot of that's optional. Stop covering that. Not a good idea. So it really leaves states in kind of a quandary. What do you do here? There's no way to cut our way out of this problem. So what we're seeing is, and I'm going to kind of make the nerd reference to Star Trek. If you ever watched the original show, or I think even in the remake, at one point Captain Kirk is sort of given this test. They call it the Kobayashi Maru, and it's intended as a no-win situation. It's a simulation intended to see how people deal with clear defeat. Of course, he cheats the system. He wins. He fixes it. And in essence, we're kind of at that point with Medicaid. Because we can't cut our way out of this problem, and we can't raise taxes to get out of this problem. So states are looking to rethink the questions. And the question they're rethinking is, wait a minute, what exactly is the problem here? Is it that we're covering people who shouldn't be covered? Is it that we're covering services that don't need to be covered? Is it that we're paying people too much? The answer to all that is no. The real core of the problem with Medicaid, turns out it's not really Medicaid's fault. Medicaid operates in the U.S. healthcare system, and the U.S. healthcare system is overly expensive, bloated, inefficient, and drives poor quality care. I think that's a blanket indictment, but I think it's fairly accurate. What do we spend in this country on healthcare? We spend 17% of our nation's GDP on healthcare in this country broadly. It may sound like a lot, I don't know, but compare us to the rest of the world. The next highest country is Switzerland at 11. We spend 50% more on healthcare as a proportion of our economy than the next highest nation. And what do we get? You can argue we have the best healthcare system in the world, but what do we really have? We've got 50 million people who are uninsured, and we have healthcare outcomes, quality measures as defined by anybody you want to talk to, IOM, World Health Organization, what have you. We don't compare with Switzerland when it comes to outcomes. We're comparing to El Salvador. And that ought to be a national tragedy. We're not getting what we deserve in terms of return on investment. And why is this? It's because the whole system is built on dysfunctional incentives. The U.S. healthcare system is built on a structure of an inefficient delivery system and of payment incentives that drive volume as opposed to quality. Healthcare in this country generally is in what we call a fee-for-service delivery model. Fee-for-service, FFS. Or as some of my friends called it, fend for self. And if you're young, if you're healthy, that's probably not a problem. You go see a doctor, break an arm, get the flu, you're okay. But you're not the problem. Healthcare in this country, as in most countries, is driven by a small number of people. 1% of the people in this country drive 25% of the spending. 5% of the people in this country drive 50% of the spending. This small cohort of folks are drowning in a confusing, fragmented, dysfunctional system. Physical health care is treated differently than mental health, is treated differently than pharmaceutical, is treated differently than long-term care. And it doesn't make any sense. We need better coordination amongst all these fragmented silos. And we need to change the incentives for everybody that operates in the system. We pay basically for volume. Every time somebody comes into the hospital, we're going to pay for it. Should they have come in the first place? Maybe not. Did they come into the hospital and get sicker while they were there? Are they bouncing back into that hospital multiple times because the hospitals failed to discharge them properly? None of that matters. We pay for it every time. And so it shouldn't surprise us that we get what we pay for. So what Medicaid's doing is the thankless task of trying to fix the U.S. healthcare system by moving away from a fee-for-service model and into more managed care. Now, managed care can be a big for-profit HMO, but it doesn't have to be. It's taking a lot of different forms. But the core concept is the same, is that you have to create some kind of entity, some nexus, where someone has the decision-making authority and the financial incentives to pay attention to the holistic health care of all of the individuals in that plan. And to have the ability to say, if I make investments to keep this person healthy, I'm not going to lose money because they're not coming into the hospital. But if I make investments to keep this person healthy, I will actually benefit. I, as the provider, I will see a profit margin by keeping somebody out of the system. Now, this is hard because this is essentially telling 17% of the nation's GDP that your business model stinks and you need to change it. And that's 17% of the nation's GDP with a lot invested in the status quo and who don't really like being told to do things differently. Question in the back already.
Yeah, already a question. I'm Tricia Pierce. I'm from the American Academy.
Do we need to wait for a mic back there? Sorry.
Thank you. I'm Tricia Pierce. I'm from the American Academy of Nurse Practitioners, and I'm a practicing nurse practitioner, so I see patients.
Thank you.
The big question I have, the big sort of question mark many of us have is, it's all well and fine to say that as a provider, you're responsible for keeping your patients out of the hospital or out of repeat visits or out of, that's all well and fine. But the fact of the matter is, as a provider, you cannot cause that patient to meet you. You have to engage your patients.
That's right.
However, the full responsibility cannot lie with the provider. And I understand that systems are being built on putting the full responsibility with the provider, but the fact of the matter is there's some patient responsibility that goes there as well. And you can't keep all your diabetics with a hemoglobin A1C where it's supposed to be if they eat ice cream every night. There's some decisions that patients make that you don't have really a whole lot of control over. So it makes us question the model that says that as a provider, you're going to get penalized if your patients don't stay out of the hospital. What happens is then you don't want to take any patients who aren't going to do exactly what they're supposed to do, and so then it reduces the care that's provided to those people who probably need it the most.
Great question, and that's exactly the problem that we're talking about.
Yeah, the answer would be really helpful.
The answer is that you need, and I'm not saying you, but we need to think about this differently. When we talk about this to physicians, we talk about this to hospitals, the first thing they say is, well, how on earth are we supposed to control the ice cream eating habits of our patient? How on earth are we supposed to ensure that once they walk out the door that they're actually going to get their prescription filled and then actually take it and be compliant with it? How on earth are we supposed to know or do anything once they leave our silo? And the answer is, well, you don't now. You're going to have to change that. And I know that's easier said than done. So the answer is, you have to build systems. You have to go where people are. You have to communicate with those patients in a way that they can understand. You're looking at me incredulously, and look, we can sit here and say, yeah, that's too hard. You know what happens? And I honestly, we're getting off on a sidetrack here because I got more stuff I want to cover, and we can debate about this all day. But if all we do is sit around and say, yep, that's just too hard, then we got two options here. We can either fix the system the right way. And fixing the system the right way means keeping people healthier, creating different incentives, paying providers to figure out this is innovation. This is why there's so much resistance. It's because we're asking people to do things differently. And you can stand up and say, nah, too hard. I don't know how to do that. You're going to do it wrong. Let's just go back to the old way of doing things because that's just fine. Well, frankly, the old way of doing things is not fine for patients, and the old way of doing things is not financially viable for anybody anymore. So things are going to change. And I say this not to be antagonistic, but I think, quite frankly, to be realistic. Change is coming. Medicaid's going to drive it because Medicaid's the one that's going broke before anybody else. But change in the system is coming. And we can stick our heads in the sand and say, nah, I don't like change. Or, nah, that change is too hard. You can either, and so I say, you can get, but you can either be at the table for discussing how we do this change or on the menu. Because you can either be part of the change and help influence the change in a way that works, or the change is going to happen to you, and I can guarantee you that will not be done in a thoughtful way, and that's not what we want to accomplish. So we can get into more of that later, but a couple other things I want to cover. But this is the context, so you can see why this is so difficult. You know, is Medicaid the ideal tool to fix 17% of the nation's GDP? No. People don't even know what it is. A lot of people who do know what it is don't like it. Doesn't pay very well. It's that program for poor people. We don't have an option. It's fix it or go under. Yes?
Just quickly, who represents the patients in Medicaid? Are there organizations? Sorry.
So the question is, who represents the patients in Medicaid? Depends. There's lots of advocacy groups. We've got AARP, represents seniors. We've got Families USA, represents pregnant women and kids. There are smaller groups out there that represent every segment you can imagine. I bet half this room is in some group that would represent the patients. So they're out there. Was that all of your question, or was that leading to something?
No, it just seems you're talking about the provider side, but who's on the patient side? Just saying, I know there are a lot of groups that represent, we are one of them, but, you know, as a whole, who
Yes.
represents Medicaid patients? And I hope it's not AARP, because I don't think, you know.
Well, that's an interesting question, and that's a challenge. That Medicaid is, as I said, very heterogeneous. We cover pregnant women and kids. We cover seniors at the end of life. We cover young adults with developmental disabilities, middle-aged people with traumatic brain injuries, working families, people with severe substance abuse and mental health disorders. Can there be a group that sufficiently represents all of them equally? Probably not. Is that something that's needed? I don't know, maybe. It certainly led to some conversations about, should we break Medicaid apart into more discrete silos so that there's a program for healthier people and a program for seniors and a program for people with disabilities? I'm not here to comment on that or talk about that, but it's an interesting question you can talk about. But this is the context. You know, the program is going to undergo change. That change is going to be scary because the people who are being forced to change aren't going to like it. Oh God, I really got the audience worked up here.
I think I think an important point to mention, and I think that Medicaid has been an experiment in this, is we talk about moving from fee-for-service to almost like a capitated model. But Medicaid, by providing lower and lower reimbursements, has actually, I think in some ways, driven a different level of care and a health disparity in some ways. And when we talk about, paying providers for good outcomes, I mean, one way to do that is to incentivize them to provide really quality care.
Sure.
And in some ways, doing things that are punitive to them is the exact opposite effect, and we've seen that. They have to see more and more patients in a smaller period of time to make ends meet. And we hear a lot about fee-for-service and physicians and providers making money off being paid for each individual service, yet over 85% of providers are actually on salary. So they don't make any more money for ordering more tests or anything like that. So it's something to really factor in when we talk about reforming Medicaid, and I think that's, something that the providers really worry about, as well as the patient advocates for that matter.
Yeah, no, we got to make the payments work. Like I said, we're spending 17% of our GDP on healthcare. We're not getting very good outcomes. I think there's enough money in the system to play around here. So anyway, strongly held beliefs on a lot of different sides here. Just trying to give you context. This is what the Medicaid directors are working on. This is what Medicaid is in the midst of, changing the way the program currently works. Change is upsetting. I get it. A couple other things to talk about. It's in the midst of all this change that we're now and have been confronting some change that's coming towards us from the federal level. So for the past couple of years, we've been thinking about implementing the Affordable Care Act, which, despite all of the talk during its debate, during its passage, after its passage, and leading up to the Supreme Court, the Affordable Care Act was not entirely about the individual mandate. The Affordable Care Act contains the largest fundamental change to Medicaid in the program's history. And as written, it would have required every state to expand coverage in a uniform way to every citizen, regardless of category, regardless of stage of their life, below 138% of the federal poverty level, an increase of up to 17 million individuals, and as well as making a number of other sort of broad changes to the program. Now, states were sort of moving forward on this. Then came the Supreme Court decision, which essentially said, Affordable Care Act's fine. Individual mandate, fine. Congress can do that. The Medicaid expansion, you can't do that. That's unconstitutional. You cannot compel the states to expand Medicaid in a manner that significantly. A decision which caught everyone, including myself, completely by surprise. But what it's done is that it's shifted the focus back towards the states, back towards Medicaid. Okay, well, now states have a choice. You can expand Medicaid or not. And what are they going to do? And so it's now turned, in essence, one of the biggest policy decisions completely over at the state level. So what are states going to do? Well, wait and see. We don't know yet. The decision about to expand or not expand is going to be a complex one. And it will be made by the governor and the state legislature. And if they're of different parties or don't agree, that'll be interesting as well. But they're going to have to weigh a complex set of factors. Political factors, whether that's the November elections at the federal level or the November elections at the state level. You know, does expanding or not expanding play well or not politically with your local base or the national one? There are also going to be financial considerations. What does it mean for your state, whether you're Mississippi or Minnesota, to do a coverage expansion of that nature? Will this be, as some have said, an immediate influx of free money flowing like manna from heaven from the federal government? Or will this actually force states to spend even more than they currently are on a program that they're having trouble sustaining? That's going to be a very, very complicated green eye shade budgetary calculation that every state's in the midst of making. But there's also going to be a whole lot of other sort of ideological questions. You know, coverage is good, sure. But is using Medicaid, with all of its inherent problems, as we've heard, in terms of what it pays providers and other challenges, is Medicaid really the best platform to expand coverage to 17 million more people? Where are all the physicians who are going to see these patients? So these are the things that states are going to be bouncing around. Complicated by the fact that we're now less than 12 months away from open enrollment of the Medicaid expansion, in theory, but as well as the 20, 25, 30 million new people who are going to get coverage through these yet to be created insurance exchanges. We're less than 12 months away from open enrollment, and we have no idea whether the administration in power next year will be repeal and replace or business as usual. Question in the back first.
Has your group had the opportunity to look at how social media can help work out some of these issues?
No.
You want to?
Sure.
We should talk.
Sure. I saw there's another question here. Yes.
Well, while you were on the topic of politics for a moment there, what's going to happen? Where we're at right now is understanding that one side, Governor Romney's side, is talking about block granting Medicaid. And it sounds like the president is, obviously perfectly fine with the Affordable Care Act. So what happens in a scenario where Medicaid gets block granted?
Good question. And I was going to lead into that to wrap up and then take a couple more questions. So the other piece that's currently out there in terms of uncertainty, in addition to our state's going to do, in addition to the uncertainty of where a state budget's going, the uncertainty of how are these reforms actually going to work? Are providers going to buy in? Our state's going to do the expansion. Who's going to win the election? The other big piece of uncertainty is, regardless of who wins the election in November, Congress is going to come back, either in lame duck or early in 2013, and to avoid sequestration, comes with a serious agenda at federal deficit reduction. And with a savings target for Medicaid, 50 billion, 80 billion, something like that. There are very few ways for the federal government to get that level of savings in Medicaid. One of which is to simply cap the federal contribution. Say, we'll give you this many dollars, but no more. A block grant, although a block grant, I find not a very helpful term, since it's a very politically loaded one, it's a very confusing one, and it's not in its traditional sense. You think about welfare as a block grant, you think about the maternal child health block grant. That's so far from the realm of possibility that it's not worth talking about. But a per capita cap, which is kind of a version of a block grant, is going to be discussed. So either cap the federal contribution, or you could just reduce the federal contribution. And actually the president has proposed this as part of his budget reductions. So it's take every state's matching rate and just reduce it. Or take some kind of discrete funding stream, provider taxes, disproportionate share hospital payments, or something like that, and just get rid of them or cut them seriously. Or, as I've heard some people start to talk about now, and again, depending on the election, if you delayed the implementation of the coverage expansions in the Affordable Care Act, the Medicaid and the exchanges, you could save $50 billion a year with a delay. So that's it. If they're actually going to be serious about making Medicaid reductions, those are their options. And each of those have very, very significant repercussions for state budgets, state reform efforts, and the decision whether or not to do the expansion. Because if a state's making a decision to do the expansion predicated on the guarantees of all of this enhanced federal match, which then gets tossed out the window as deficit reduction, people are going to want to be real careful about that. So, we can talk more about what changes does a block grant or a per capita cap bring? Unknown. Because the devil's in the details. I mean, it would cap the federal exposure, but what's your baseline? What's your growth rate? Those things aren't being talked about. That makes all the difference in the world. And then the other question is, the trade-off for those has always been the feds give the states less money, but give them more flexibility, for lack of a better word, to make it happen within that smaller amount. Okay, what does that mean? Which of the hundreds of thousands of pages of rules and regulations are you getting rid of? No one's talked about that either. So at this point, it's completely hypothetical. There's a lot of really hard decisions that have to get made to get there, but we're just nowhere near that yet.
So I'm with NAMI, and we are a patient advocacy organization for people with serious mental illness. And I just wanted to say that I heard you reference Medicaid managed care, which we've had in the past in some disastrous outcomes in states like TennCare.
Sure.
So I guess my concern is I hope we're not looking to managed care as an innovative solution, since it tends to set up a gatekeeper system and doesn't necessarily incentivize care coordination. And I hope we're looking toward technology and some of the things we've heard about here that really engage, and this gets back to the engagement issue, which I think the nurse practitioner group mentioned, people in new and innovative ways, and peer support services and innovative services that I think in the Medicaid system, there hasn't been a tendency to necessarily pay for if it's outside of a traditional medical model. So I guess I'm just saying I think that in engaging families to provide care coordination and consumers. And so I know the Medicaid system is not always on the cutting edge of technology because there isn't always the money to invest in that kind of innovation, but there certainly have been some very cool things talked about here.
Sure, and that's a great question. I will argue that the managed care, and when I say managed care, I'm doing this, the quotation marks, because it's not necessarily just capitated. It can be. But the managed care we're looking at today is different than the managed care that we did back in the 90s. Yes, I mean, there were big disasters. There were failures. Early TennCare was one of them. TennCare today has learned its lessons. TennCare, I would argue, is a model for the nation. And the key difference, I think, is part of what states have had to do is reorient how state government works, reorient how Medicaid agencies work. So it's not just, I said we have to move away from fee-for-service and that kind of, state agencies used to be full of a bunch of bill payers. File a claim, we'll pay it. Okay. The skill set of state agency staff has changed, and it's become oriented around three things. One, writing strong, quality-focused contracts. You get what you pay for, you get what you incentivize, and you get what you contract for. So you have to write the contract in the right way. Incentives for quality, penalties for lack thereof. But it's not good enough just to write it. You have to be able to oversee it in an ongoing fashion. How are those plans, or whatever the managed care arrangement is, how are they actually functioning? How are they actually working day to day? Are there spikes in inappropriate utilization, over, under, what have you? You have to know what's happening. And then three, if you see something that's wrong, enforcement. You have to be able to be nimble and sophisticated enough so that if at any point the plan is not performing in the way that you hope, you step in and you correct it. That's the key. That's what we're seeing in Tennessee now. That's what we're seeing in places like Arizona, in so many other states. And you're right. I mean, there isn't really money in Medicaid proper to be really, there isn't money, there isn't bandwidth, there isn't people time to do a lot of these individual innovations, whether they're social media related or technology related or what have you. But that's where I do think that the role of some kind of, again, managed care comes in. You know, Medicaid, federal law requires us to pay only for services, Medicaid services, delivered to a Medicaid patient by a Medicaid physician. And if it gets outside of that, the feds get really upset. Now, that's where these new arrangements, managed care or what have you, we give them the money and the authority to be able to look across all of these silos and the incentives to go to be innovative, to figure out how to engage the family, the patient, the community. Is that going to be easy? No. But if we can't figure out how to innovate on this, then we're doomed. Now, I think there are going to be some changes needed because, you know, one of the challenges Medicaid's always had is a distinct lack of ability to really engage patients in any kind of participatory way. And, you know, the ability to do cost sharing in any significant way is almost non-existent. You know, we're not looking to say, okay, well, you know, got to pay $50 a month for your statins or your, you know, $100 a visit for your diabetes treatments, what have you. But, you know, if you need an MRI, there's a center right here that is low cost, high quality. You want to go there? Good, go there, free. You want to go clear across town to the teaching hospital where it's 5 times as much, costs 5 times as much and the quality is sketchy? You can still go. That'll cost you $50. Or with prescription drugs. You need something to treat a condition? We've got that. It's free. You want the thing you just saw on TV for your restless leg syndrome or whatever? You can have it. There's going to be a copay. We can't do that today. Federal law's got to change on that.
Matt, you're brilliant. So the things you're talking about are gigantic problems. And I guess as the person who represents the 50 men and women who are the stewards of the 50 Medicaid programs around the country, how can we, as patient advocacy organizations, make their lives better?
I think the answer is in, quite frankly, recognizing. You know, if you're a patient advocacy organization, in all likelihood, you're representing patients who are not healthy folks, for the most part. The less than healthy, the sicker, the frailer, the more vulnerable, I would argue, and I think I would be backed up by this, do not get treated very well in the current healthcare system. We could spend a lot of time talking about the dual eligibles. We don't really have enough time for that because I know we got to switch to some other stuff. This is a group that is the oldest, the frailest, the sickest, the most disabled in this country. And I would argue they get the worst care. The status quo for a lot of really sick, frail, vulnerable people is terrible. Demand better. Don't just say, we're fine, we don't like change, we don't want to do this. If you can meet us halfway and say, yes, status quo has got to change, let's figure out how to do that. Be a part of that solution. Whether it's dual eligibles, individuals with severe persistent mental illness, whatever. We know that we can collectively do better, and that will have better patient outcomes, and that ideally that will have lower cost to the system. Let's figure out a way together to get there. And I think on behalf of all of my members, I would say, and maybe this is a good stopping point, be a part of the solution. We want to engage. We know that we can't move forward. We're not going to move out. We're not going to move off of the dime. We're not going to move off of a dysfunctional fee-for-service system if the automatic default response is no, because change is scary. Because what you might do might be worse than the awful situation we're in. Then we're just going to get nowhere. And then that will force really, really uncomfortable decisions at the end of the day. Engage.